Hello and welcome to ACL Wise. My name is Tom Jacobs, and this episode we have a special guest who is a renowned orthopaedic knee consultant and surgeon to the stars, Andy Williams. And we'll be talking about all things ACL injury assessment and also the role of biomechanics in the injury and also choice of surgery management. So let's crack on. Most of the people who know orthopedics will know who you are. Any of the physios or rehabilitators who don't know you as well, could you just kick us off by telling us a little bit why you got into sports injuries of the knee and why you've ended up at this place as well?
Yeah, I mean, it's interesting, isn't it? Well, first of all, I feel very lucky to do what I do and privileged. Choosing where to go is quite difficult when you're young. But what actually happens is you'll meet people who inspire you, who really get into your head and you think, God, I'd love to do that or emulate them. And my first job was with a knee surgeon in Croydon, Michael Mowbray, very kindly, very able man, and I just loved what he was doing. I could see myself doing that job, and I'm forever grateful for him for that. And then I got a job at Stanmore, working with Professor George Bentley, who's brain the size of a planet, amazing individual. I worked for Rolf Birch, who's sadly passed away actually. And Rolf was just a genius. He was a brachial plexus surgeon, a peripheral nerve surgeon. His skill, his knowledge, his intellect, his passion for the patients was incredible. So you have a couple of inspiring people like that, and then ultimately I went to do a fellowship in Australia in Brisbane. And 1 year I probably saw 5 years worth of knees training wise in the UK because we do other things. And that really showed me where the bar was set. I worked with two Peters, Peter McMenamin and Peter Myers, and that year was truly extraordinary. It turned me from I think a good trainee in my opinion, but while I was out there I saw a lot of professionals, athletes being treated by Peter Myers in particular, and I just thought I want to do that. And I realised that I had to do research, I had to get a teaching hospital type job. Bizarrely, my first ever club was Chelsea Football Club, weirdly. And then Brighton phoned them up, said, who looks after your knees? It was Andy. So then I got a guy who is old enough now, because it was so long ago, that his son is a Premiership footballer. And when he walked in to see me, I said, I think I know your dad. There's an unusual surname. And it's just the word of mouth thing goes. And I was in Australia where I decided I wanted it. I knew it was going to be onerous. But I've never been one to turn down a challenge. And the amazing thing about treating sports people is they teach you so much. They get ordinary things for the general population, but they're exaggerated out of all proportion. And they also get rare things. And so it made me so much better at my work for everybody.
And perhaps you don't get that hyper-focus testing environment like you get in elite sport.
Yeah, no, that's really right. I mean, when you're there in a consultation, there's a player, the agent, the doctor, the physio,
pressure's on.
You've got to be on top form. And, it's funny, we were just joking before we started, I've just come over from a holiday, I'm not match fit.
No.
Even when I dictate now, it's inefficient.
The brain, just trying to get the cogs going.
Yeah, well, I've had a good holiday, that's a problem.
Yeah, nice, very nice. That's important too. So there are real upsides then to the elite sports sector. Follow-up management, data, these sorts of things really allow you to hone over years what you do.
And also the downward pressure from them. They ask questions we've got to come up with answers for. And so we wouldn't have ACL surgery as good as it is today without the clubs, without the athletes, without the owners. If an owner loses a player with an ACL, that's a massive financial hit for that club.
Yes.
Certainly in rugby, for example. And they have a great interest in prevention of ACL rupture, but also a great interest is in operations that work first time.
Yeah.
And that don't fail and have to be redone.
That's interesting because business is often a driver of innovation.
Yes.
Because money talks.
Yes, indeed.
And I hadn't thought of that. Perhaps that then impacts the non-elite population because it would change practices
right.
outside of the elite sector, right?
And so, generally speaking, I would treat a non-professional sports person or a general population person exactly as I would with an athlete, with one or two exceptions. One of the problems that the general population have is they're just not as robust physically, mentally as the athletes. So the athletes, there's a selected bunch of people who do pain. Rugby players' ability to withstand pain and yet perform. There is a professional female football player I saw that the other night on TV. She's got bone and bone arthritis. She is hard as hell. I admire her so much. She's one of my favourite people. Her robustness. You can do big operations on those people because they can deal with it.
Yeah, yeah. So there's a robustness, though, there, isn't there? There's a different relationship to pain.
Absolutely.
Than the general
They
populace,
almost
perhaps.
embrace it. Many people at my age, just over 60, would attest every morning you wake up and something hurts. You just have to get on with it. But I've developed this incredible determination to work, to perform, if you like.
You've been inspired by your patients, maybe a little bit.
Just get on with it.
Yeah. No, but you're not a shirker. That's well known.
Oh, that's true.
Are there no downsides then to working with the elite population?
Of course there are. You should speak to my wife. It's a 7-day-a-week job. I'm going to Australia tomorrow, as you know, to do some work, but also watch some rugby. And I will be called every day, and I will be looking at scans online in Australia, making calls back here. And it's part of my life, and it's relentless and out of hours, and it's antisocial. But you have to deliver a service, otherwise you're not at the races. And I know, a lot of people, a lot of surgeons perhaps a bit envious of what I do, but I honestly don't think they realise what's involved. And the sort of old days where the local surgeon would look after the local team are sort of gone, because the demands on the players and the teams is such that they will go anywhere for expertise. And so I'm very grateful to them and fortunate that they're happy to travel.
I wanted to ask you a couple of things. One is, up in Edinburgh at the orthopaedic conference a couple of months ago, you were talking a little bit about assessment of ACLs. Obviously, the development of MRI scanning has been fantastic.
Amazing.
And really good. Do you feel clinicians lean too much? I mean, there's physios and sports therapists and all sorts of people who'll be watching this. Do you feel like we lean too much on MRI scanning?
Well, it's true of all medicine. Investigations, Western medicine involves tests. And certainly in orthopaedics, one of the joys of what I do is the physical contact, the manual skills that you develop to examine a knee properly. And it's become a lost art. It's really, it's quite shocking. And I mean, I can't believe it, because I look at every MRI scan I order myself. I happen to work with world-class radiologists, and they know I read the scans myself. And occasionally I will read their report. And it seems insulting to them that just I do so much. Yeah. But they save my backside probably 3 or 4 times every year. So radiology is amazing. MRI is amazing. But you've got to remember, an MRI scan shows water content of tissue. Yeah. And that can exaggerate some things the opposite way as well. It's static. And it tells you what's wrong, but it doesn't tell you how wrong. So if you see edema in something, there's an injury to it. But is it intact or not? Only these can tell you in your eyes. And so I'm very, very passionate about good examination of the knee. And the problem with MRI is it makes life too easy. And there are some cases who get booked for surgery without even being examined. I find it shocking. ACLs aren't just ACLs. It's a global injury of the knee. Usually the lateral femoral condyle comes off the back of the lateral tibia. When that happens, when that rotation happens, here's the lateral femoral condyle, comes off the back. Guess what? The lateral meniscus moves with it, the capsule gets torn, post-lateral corner is at risk. But also, as that's happening, on the medial side, it's doing that. And we get damage to deep MCL, which is my new favourite topic, sometimes a super MCL. And so we should be examining for those things, because if you miss excess laxity medially or laterally, it's a very good reason a good ACL reconstruction will fail. Frank Noyce used to say that the most common reason for a good ACL done well failed was unaddressed post-lateral corner insufficiency. In fact, I think he's wrong. I think it's medial. And we're very casual about the medial ligament. Oh, it heals itself, takes care of itself. Well, usually, but not always.
So your fine feel or MCL stress testing in someone who you're suspicious of an ACL injury could have a significant bearing
Absolutely right.
on what's passed on to the orthopaedic surgeon.
I've been burnt before. I had a young footballer who had an ACL with me, did great, then got a small MCL. And most people you put up with grade 1 laxity, it then re-ruptured his ACL because that opening stressed the ACL.
Do you think we should be hinge bracing everyone with a suspected ACL injury?
No, I brace less and less. Or do you mean non-operatively?
As soon as they've injured. So a lot of the clinicians who'll be seeing this sort of thing, they might be seeing someone who's come in with a fresh injury. They've got a big old hemarthrosis. They don't know what it is.
Yeah.
Course history is going to be massive. Probably the biggest thing before they do an examination. But if they're suspicious of an ACL rupture, which a lot of the bottom of the pyramid will be picked up by these allied health clinicians, right? Taking your point in mind, an assumption of an MCL grade 1, grade 2, let's say, or even a posterior lateral corn injury,
Yes.
would possibly be helped a bit by some early bracing.
It could be. There's a price for bracing. One of the most common is that people think they're straight in the brace. They're not. And the most common cause of real trouble with knee injury and knee surgery is fixed flexion deformity. Yeah. You've got to get the knee straight as soon as possible. And a brace can sometimes hinder that. But if you think there's collateral damage, then it's logical to put a brace on. I wouldn't restrict range because pain stops people. And I am bracing less and less, interestingly.
Do some heal long if they're missed?
They can do. And that's potentially a problem for your ACL later. But the one of the key things when you examine the knee is to make sure that it's pretty basic. Make sure that the tibia and femur start in the right place. If you start examining a knee that's subluxed, so if you do a classic examination of MCL holding the proximal tibia below the joint line and you've got ACL deficiency, the femur drops back with gravity. You've got a subluxed joint which tightens up the loose MCL. It feels great. What you need to do is put your hand proximal to the joint under the back of the femur, let the tibia drop back with gravity, and then hold the foot and move it side to side. And I got a nice video, you may have seen it, where there was no MCL laxity, and then I examined it properly, reduce it. Why? It's grade 2, and that woman needed to have an MCL as well as ACL.
Yeah.
And we also think too simplistically of ligaments. So we think, what's the MCL do? It resists valgus. Well, actually, it's got a very important job at resisting external rotation.
And hyperextension to
and hyperextension posteriorly. So these are ligament complexes. The post-lateral corner is the LCL for varus. It's the popliteus complex, which is the popliteal fibula ligament for controlling rotation. But it's not as simple as that because it's got a muscle that dynamizes it. And so when you pop the ACL in the middle of the joint, the reality is the periphery is damaged. You can't rupture an ACL without doing something to the periphery. And so the concept of a truly isolated ACL, well, actually, it's a really rare scenario.
So the nuance there is important. Well, what have you learned from dynamic MRI imaging? I know you've done some stuff in this space. Has that changed what you've done on the ground or clinical practice in any way or not?
I was called up by a radiologist at St Mary's, and we got this scanner you can stand up in. I want you to come do some research there. And the reason he phoned me was my wife's a radiologist at St Mary's.
Oh, right.
And I said, well, I can't. I've got to go back to work. And Prof wants me. And anyway, Prof was brilliant. He sat me down. He said, look, Andy, he said, is this going to be a good thing? I said, it's amazing. It's the first time we ever imaged the living human knee weight bearing in 3 dimensions. The X-ray is great, but it's 2-dimensional. So he said, look, let me have a chat. So he spoke to the professor, radiologist, and he said, Andy can't come. He's busy. He's going to work for me. He said, but he could supervise somebody. So the first things we looked at was meniscal motion. And that was pretty cool. Medial meniscus, posterior horn doesn't move very much at all. The lateral meniscus, wow, it moves 25, 30 millimeters forward and back. And I assumed that the model of knee motion that I'd learned as a registrar, that on the top of the tibia, if you just spin on the spot, you won't be able to bend very far. So to get clearance, the back of the knee, and this worked largely for Oxford, there's something called rollback. So as the femur spins on the spot, it also rolls back, and you get clearance to the back of the tibia, and you get deep flexion. And the idea was that happened medially and laterally, and that improved the lever arm for the patellofemoral joint as well. So mechanical advantage getting out of a chair, going upstairs. So it all stacked up nicely. Every knee replacement ever designed up until our research involved either keeping the PCL intact to pull the femur back, or using a cam post mechanism, so the post on the tibia hit the femur and drove it all back. But just by luck, we found out that whilst laterally it does largely roll all the way back, and it's extraordinary laterally, the femur almost comes off the back of the tibia. On the medial side, it's almost a ball in the socket. it spins on the spot with no AP movement until you get to 120 degrees, it jerks back a bit. So suddenly we see this differential motion. And in fact, what happens when you flex your knee is that the tibia internally rotates. If you watch school kids all on their knees from behind, all their feet are turned in. And if you try and do the squat in maximum external rotation, you can't get very far. You get about 100 degrees. And so the lucky thing for me, and it really was lucky, was there was something very different to talk about. I travelled all over the world talking about knee motion. And so it did lead to some design changes in knee replacement.
An area of interest for me is, as you probably would have guessed, is this bit around injury risk and the biomechanics of that. I know that's another area you've had addressed in the past. What do you feel around, what have you learnt around the biomechanics of ACL rupture, and therefore what that sort of poses as a risk for people?
Well, first up, there are some poor people who are predestined to rupture their ACLs if they are exposed to risk. And that risk can be pretty low stuff, low-level sport at school, for example. And we've published, I think, 232 professional footballers, ACL reconstruction results. From memory, I think it was 30%. It could have been as low as 25%. That's not low. Rupture their other ACL. So there's obviously something about their knees that's trouble. And there's all sorts of factors, the coronal alignment's important. If you've got a valgus knee, you're much higher risk. If you're a hyperextender, you're much higher risk. If your ligaments are lax, you're at much higher risk. There's a family history, etc. The menstrual cycle, all sorts of things are involved in ligament laxity. And when the stars align, they're vulnerable. But for some people, the stars will never align because they're better aligned, they're stiffer, they've got better muscle control. But the injury mechanism is fascinating because we thought we understood it. If you look at an MRI scan, because of the subluxation that occurs laterally, this is what happens. There's a bone bruise usually on the back of the tibia laterally and the centre of the femoral condyle. Because of that internal rotation, the tibia internally rotates, femur falls off the back. Your ACL goes pop. But there's been great work from the isokinetic group on video analysis of injuries, and they all occur in external rotation and valgus. So the MRI shows us 2 bone bruises laterally that can only have occurred with the femur off the back of the lateral, and that's internal rotation. So I used to think I understood it. I thought the tibia internally rotated, tends to the ACL, it ruptured. Every football video I see, they dummy, maybe press somebody, get thrown off balance, they've got their foot planted externally, sometimes way externally, and a bit of valgus, and they rupture. So I don't know quite how it happens, to be honest with you. What I do know is that there are some makeups of knees that are at risk, but the subtleties we don't understand. But we're getting there.
I mean, it's a very complex biomechanical unit, and I think Edna King presented something when we were in Edinburgh as well around this business of external rotation, relative external rotation, but then the knee dropping into valgus, and that somehow that tensions and
ends up the other way.
Yeah.
And so what I don't know is whether the ACL breaks in the external rotation position, or somebody gets rebound internal rotation happens then.
I think that was his.
I used to think I understood it. There is one mechanism that is much less common, and that's pure hyperextension. Those injuries, you see bone bruising at the front of the knee where it's crunched down, and you usually see a proximal pull-off of the ACL. So that's logical, I get that. But the rotational injuries, which cost them vast majority...
the non-contact.
Step, move, and fall over. I really don't know how it happens. So it's interesting.
In terms of, this is a question I ask everybody, if there is one thing in the years ahead, in terms of this whole world of ACL management, that you'd like to see in the UK, what would that be?
Oh, that's a really good question. I mean, the key thing is to stop it happening, if we can. I'm a little depressed about a number of aspects of that. One is, you'd think that the schools, the clubs be really interested in it. I remember writing a letter to my daughter's school, trying to encourage female sport participation, the benefits for increasing bone mass before you start to deteriorate in your early 20s. I didn't even get a reply. And I spoke to a boys' school, across the river in the Thames. I spoke to the head of rugby there about concussion. And honestly, there was very little interest. So first of all, I think the population need to understand it. They'll help get behind moves to prevent. The schools need to take it seriously. The clubs need to take it seriously. Then the final piece is, well, what do you do about it? There are some people just put together very badly. They're in trouble. Someone very close to me has got very bad alignment, rotational alignment, and she skis. I'm sure she'll do her ACL, but am I going to tell her not to ski? No, she loves it, but she ain't designed for it, poor thing. And we've got to try and mitigate the risk, and the best way to do that is by enhancing neuromuscular control. Sure, bracing, taping can help a bit. Orthotics, arguably. Prophylactic bracing doesn't help. There was an American football team, an NFL team, whose owner, understandably, was sick and tired of losing his livestock with ACL. So he said, right, you're allowed to wear braces. So the whole team had to wear braces all season. They actually had slightly more ruptures that year than the following. It wasn't significant.
Why might neuromuscular control have an impact on someone's ability or risk, if you like, to rupture their ACL?
The simple thing is, I used to love in the playground going up behind a mate and knocking his knee away from behind.
We all did that.
Yes, they've got normal ligaments, normal proprioception, but when we can stand with our quads relaxed. Yeah. We cut them unawares and down they go. And so we need neuromuscular control for stability. So the most common cause of instability is impaired neuromuscular control. It may be inhibition from hemarthrosis, inhibition from pain, but also conditioning. And now that I'm 61, I've had 2 major knee operations in a year. I had to have it redone because I was an idiot, went back to work too soon. But I feel really vulnerable at the moment. Not psychologically, obviously, but just physically. And even things, I'm not match fit. Hopefully with work in the gym, I'm going to get there. I wouldn't dream of running. I'd choose the shoes carefully. If a new pair of shoes with a shiny sole, I don't put them on.
You get vulnerability.
Yeah, because I know I'm not stable. Footballers have all got bow legs. As they walk, you don't see them for lateral thrust. And why is that? Well, it's because lateral gastroc, IT band with TFL, biceps, all fire at the split second that's required to prevent the joint opening. And they dissipate the force. If you blow an ACL in that player, and you fix the ACL, everyone's happy. But over the months and years, because of the proprioceptive deficit from the ACL loss, which you cannot restore with a simple graft, they'll develop a thrust over the years. They get a post-lateral corner stretch out.
Interesting.
The ACL surgery we do relatively crude. The integration of muscle balance, all the data coming back from the limbs through proprioception is extraordinarily complex. And that's beautiful. Whereas our stuff is a bit crude. We just stop things moving.
So if I was going to pin you down then on that point around the one thing that you feel would make the biggest difference, you mentioned about prevention being better than cure. In this country, there are other countries who are doing things a bit differently, but in this country, what do you feel would have the biggest impact?
So a very simple answer, and it's an awful conversation. I grew up thinking that all doctors were equally good. Because I'm now in the business, I realise that's not the case.
No, sure.
And I remember being at a meeting where 2 ex-doctors who worked for consultancy companies, one was working for McKinsey's on healthcare. They said, guys, it drives us nuts every year, the bills go up. But we sort of get our head around it because you keep inventing expensive things and medicine gets more expensive. But the thing we cannot get our head around as healthcare purchasers is variability of outcome. How come if you go to the Martini Clinic in Germany and have a radical prostatectomy for your cancer, you have a less than 1% risk of impotence and incontinence? And there are some places in the UK it's been 30%. That may have improved over the 10 years since I was given that stat. But it's to illustrate the point. I know who would do my ACL or my kid's ACL. I also know who would not do it. And it is staggering in 2025 that first of all the diagnosis is missed in A&E and at front of house regularly. Second, that the decision making regarding surgery and how to do it is so variable. And then thirdly, that the surgeons can't put the graft in the right place every time.
to quality of the clinician, skill of the clinician.
So one of the things I'm working on is robotic surgery to put the blinking graft in the right place. I was involved in a lawsuit, I can talk about it because it's in the public domain, where a posterior cruciate ligament restructure was undertaken. It probably was never needed. Arthroscopy 1 week, 2 weeks later, the surgeon operated on a championship player, footballer, did a PCL that was so negligent that the femoral tunnel exploded the mediofemoral condyle. And the tibial tunnel, when I got to see the pictures, was like an ACL way forward. And how can that be allowed to happen? How can the incompetence of a surgeon be tolerated? But unfortunately, there is massive variability.
It's an interesting, quite pertinent topic. Having in the rehab space as well at the moment about measuring outcomes.
It's very hard.
Looking at quality of rehabilitation.
And a physio who's under so much pressure, in the private sector, the prices I see are being driven down and down and down. It's so hard to measure outcome. And it, as you know, with any practitioner, as well as the knowledge, expertise, skills, there's also the charisma of the
affability.
And patients respond to that. Patients who are happy and who trust their treating professional do better. How can you measure that?
And that's partly what this podcast is about, because if we can improve quality through education and disseminating the information out there, and that's been a real learning point for me over the past 4 or 5 years, is to go, okay, we should be having these conversations. We should be talking about...
They're awkward conversations, but even within our clinic, in our hospital, we all do ACLs differently. Now, I passionately believe that my colleagues should be reading my research and doing it my way, but because I'm biased, and they still do a great job, by the way, so I'm teasing a bit, but it shouldn't be this variable. So from a surgeon's point of view, the biggest change we could do for the better is to get consistency in result.
Consistency and more parity across the recovery. And also, wherever possible, improve people's strength and conditioning.
Oh, so I frequently say it, I mean it, I promise. I'll say to the player, you need to thank him or her for making me look good, i.e. the physiotherapist, because there is some crazy stuff goes on in pro sport because it attracts gurus, it attracts people who are there perhaps for the wrong reasons. I'm blessed by having amazing people around me that make me look good a lot of the time, but I'm also really interested in what they're doing. If I don't know them, we have to get to know each other because I'm anxious.
Yeah. No, but that trust is really important.
It's very simple. It's a team effort. I don't care how they get better as long as they get better.
I think we've got to draw things to a close. You've got other things to do today. But Andy Williams, thanks very much for your time.
Real pleasure.
And
real pleasure.
We'd like to do it again sometime. That's all for now. See us again in the next episode. Don't forget to subscribe and follow, and we'll see you in the next one.